Hey, this is Dr. Livingston, and here's our lecture on laboratory tests and interpretation. Now, I did not create this all by myself. A lot of this was adapted from a lecture given by Dr. Michael Cozart. So here's just a list of all of the labs that we're going to review in this lecture. So first off, we got to understand why we're ordering labs in the first place. So the little list there at the top is just kind of just a little summary of some of the reasons that we do. So the primary thing that we get most of our labs is to watch out for and monitor any ongoing potential, biologic or metabolic responses to any of our medications. We do have some of those, obviously. With a lot of the meds that we're going to cover today, it's going to be therapeutic monitoring of some serum levels. We're also watching out for some of those adverse reactions that can happen. A lot of these do have some physiologic adverse reactions that can happen. So we definitely want to watch out for those. And then, of course, those can be exacerbated or that risk increased if there are any underlying conditions. Now, sometimes we have to keep in mind that our patients don't always have, or they might not have a primary care, and if they do, they might not see that primary care very often. So there could be some things that, the labs that we order and for our purposes, might actually kind of show some other issues going on. So things to keep in mind. Now, when we are interpreting these labs, we do have to keep in mind, was it fasting? When was the last dose taken? Sorry. What is their medical history? What's their, does their medical history alter that baseline of what is kind of considered their normal? We also have to look at their previous baseline results. And this is why we want to get some of these labs before we ever start, so we can get that good baseline of, did the medication cause the abnormal or not? And then we definitely want to make sure that that the labs were obtained as a trough level. So that's going to be 10 to 12 hours after the last dose. Most of these medications are going to be dosed twice a day. So, for the most part, we really just want to tell patients, like, if you're going to get them done in the morning, which usually tends to be a little bit easier to kind of keep patients used to that, just so that, if we do happen to have to get a fasting lab, it's just kind of, yes, I'm fasting, here's my labs. But I always have told my patients, just, doesn't matter when you get the actual, if I'm just ordering the medication level, doesn't matter when you get it, just as long as you get it within a couple of hours before you take your next dose, whenever that may be. Now let's start off with lithium. We've talked about lithium in psychopharmacology and also in 541, and we will. I don't think we've gotten there quite yet. In 542. Oh wait, no, it's this week. How about that? We might get brought up with bipolar disorder this week. But we also use it to treat mania, and it's one of the best for specifically for decreasing suicidal ideation and suicidality. It is a naturally occurring element, just in case anybody was unaware of that. It is a naturally occurring salt. And there's some interesting stories behind that, but I will not veer off course in this one. All right, so here's just a reminder. We've talked about all of this stuff in psychopharmacology, but this is just kind of a reminder slide. Something to keep in mind is with the relationship with sodium. Low sodium is going to equal higher lithium level. Okay? High sodium level is going to equal low lithium level. All right? So keep that in mind, because they are both salts. All right? So now the labs that we're going to get. Before we start, and again, all of these, before you start, before initiation, we can't always get them. Sometimes it's just not, it's just not available for whatever reason. But we do want to try and get these baseline. Now, for these that are going to be teratogenic, we for sure want to get a pregnancy test on anybody that could possibly be pregnant before we start it. That's just more of a negligence type of thing. And also, I'll go ahead and say this while I'm at it. Some of the labs that we're going to talk about today are not necessarily quote unquote required, standard practice, but they are highly recommended. Now, here's the thing. If you choose not to obtain recommended labs and you're sticking with just the required ones for standard practice, then if something happens and it is traced back to being caused by a medication that you have prescribed and you have chosen not to monitor for that potential risk, then you can find yourself at the end of a lawsuit, or at the receiving end, rather, of a lawsuit. So just keep that in mind. Do with that what you will, but safe practices. So okay, so we're going to get those initial labs: pregnancy test, comprehensive panel, thyroid panel, and an EKG. And before I get any further, when you are learning the specific labs for specific individual medications, think about the side effects that are associated with the medications. We get the labs to monitor for the side effects and the risks, so it's going to make sense. For example, with lithium, pregnancy, teratogenic, comp, sodium, kidney function, electrolyte balances, things like that, right? All of those things. We can also see some rare blood dyscrasias in there, so we're going to monitor for it just in case. I'm sorry, that would ignore that. I'm thinking CBC. We're not getting a CBC with lithium, but that would be a reason that we would get a CBC with other ones. With lithium, we've got that thyroid panel because it can do damage to the function of the thyroid, and EKG because it can do damage to cardiac rhythms. So that's why we're getting those. All right, so when do we get them? Well, it takes lithium about 5 days after a new dose, like if you're already on it, takes about 5 days to get to steady state. Can take anywhere from 5 to 7 days to get to steady state with a starting dose. And that just kind of depends on the person's metabolism. So 7 days is about as long as we want to go, but we don't want to obtain it any earlier than 5 days after initiation because we're not going to get an accurate level there. So on our kind of like our routine to just check that level, right? After we've started it, we're gonna get that level, trough level, and then we're gonna get another comp. And then if that's normal, then every 6 months or within 7 days of any dose increase, we're gonna get another lithium level, we're gonna get another comp, and we're gonna get a thyroid. The lithium panel that you see there kind of it encompasses all of that, but those are the specific things that we're looking for in that CMP. And then we're going to do an EKG once a year unless it's abnormal. We're going to get it more frequently than that if it's abnormal. So now that we've got our labs with lithium, what do we do with those results? So obviously if someone is pregnant or breastfeeding, we're going to stop the lithium immediately or just don't start it in the first place. And if we see dehydration, now this is going to be a little different because with dehydration, of course, we might actually see our sodium levels be high or low depending on the source of the dehydration. However, our concerning point is going to be if sodium levels are below 136. If it's below 136, that means our lithium levels are going to be higher. That's where we're concerned. With our BUN and creatinine, of course, that's going to be a greater ratio than 20 to 1. And that's where we're going to be more concerned there. Then when we get to our GFR, a lot of times people don't really monitor GFR in younger folks or people that don't already have renal disease of some sort. So we do have to kind of take this one into context of the person's overall health and what's going on in some of their other, we'll say, renal panel labs. But in general, if we see a GFR that is below 60 or a creatinine that's greater than 1.2, that's going to be indicative of something, some sort of renal disease. So kind of keep in mind, BUN creatinine is more indicative of dehydration, and then our GFR is going to be more indicative of our actual renal function. And since lithium does impact renal function, those are things that we need to look at. And then we want to check for hypothyroidism, and that's going to be shown with a TSH that is greater than 4.5, or possibly just a significant increase from their baseline. Remembering that everybody's baseline is different, even if it's still remains within normal limits. Someone could start off on the lower end of normal, have a significant elevation from baseline, and still be within normal limits. So we have to, we got to take that on a case-by-case basis. Of course, with lithium, we can also have some cardiac arrhythmias. So any significant change in EKG from baseline. Now, that does not necessarily mean that we're going to stop lithium just because we've had a change, but it does depend on what that change was and how significant it is. Now, when we get lab results back, we're going to consider these things an emergency. If we have a sudden rise in creatinine or a sudden drop in GFR, if we have a sudden rise in TSH, especially if that TSH gets above 10, that's an emergency. And then if we have a lithium level that's over 2.0, we're gonna have to do something about that. Lower than that, we can definitely monitor on an outpatient basis, make adjustments, things like that. But once it gets to 2, then we might actually have to do something else in that process, and we'll talk about that in just a second. All right, so here's our ranges with that lithium level. Now, this is assuming that we have gotten, a trough level. All right. If we are just doing maintenance doses, okay, they're good, they're stable, we're just maintaining. Our maintenance range is going to be about 0.7 to 1.0. If we are treating mania, like an active acute mania, we want a higher range, so it's going to be more of a 1 to 1.5. If we are treating just for depression, we can maintain at a slightly lower level with a 0.6 as compared to that maintenance dose, but we can also maintain up to a level of 1. Now, for the most part, we want to keep that level no more than 1, obviously, unless we're dealing with mania. But 1.2 is probably about the highest that we really want to go, because anything over that is really going to put folks at a significant increased risk for side effects. Research has shown that there really isn't much benefit maintaining at a level lower than 0.5 or a level higher than 1. So that's kind of the range that we want to stay in. But again, if we're really looking for that true range, it's a 0.5 to a 1.2 that's kind of the cutoff. Now this just kind of goes back toward those trough levels. Keep in mind, if you have someone taking their lithium and they're only taking it at night, then that is actually going to cause those AM trough levels to be 10 to 20% higher than typical. So just keep that in mind, right? If you're dosing it twice a day, it's not that much higher. So it's just kind of interesting. Any trough level that is over a 1.5, we've got some pretty serious risk or serious increased risk for serious side effects. And these are some of the things that we're going to see. And those are going to be, those are our signs of lithium toxicity. I can't remember if I've said this or not yet. I feel like I said it on the previous slide, but just to make sure that I did, lithium does take about 5 days to get to steady state. So just keep that in mind. So that's why we're not going to get anything, we're not going to draw a level sooner than 5 days, but at max 7 days. Right? So what do we do if we do have that abnormal high? Well, first of all, we want to ask and find out if it is a true trough level. The reason for that is because obviously if they just took their medication, it's going to be higher. Now, I guess a range to keep in mind is that about 2 to 4 hours after taking a dose, levels are going to be abnormally high. Like that's just kind of a given. It's going to happen. So we have to keep that in mind. We have to know when did they last, or when did they take their last dose. I've had some folks that I get like a critically high level come back, and then I call them, I'm like, when did you take your medication? They're like, oh, right before I left the house to go get my labs. I knew you needed a level. I'm like, no, you didn't understand. Or maybe I wasn't clear. I don't know. That's not what we needed to do. So there's that. Length of time on the current dose. Okay. We have to await that steady state, because prior to that, we're going to have a pretty unstable level. We'll say it's going to be really, really high after dosing. It's going to be really, really low on that trough level. So we're just going to be all over the place. So we have to really just make sure that we've got a proper, time frame there. And then also ask the patient, like, what have you been eating and drinking lately? Have there been any big changes? Because that sodium, remember, is going to affect our lithium levels. If sodium levels are low, our lithium levels are going to be high. If sodium levels are high, our lithium levels will be low. So we have to keep that in mind. We want to look at, our other possible causes. That's probably supposed to say higher dose. Did we just increase the dose? High AM dose. That's what I meant on that, high AM dose. So if their morning dose is high and they did just what I just said, they took it right before they got their labs drawn, then we're going to have a critically high. If they are taking NSAIDs, we're going to have a higher level. And then again, if sodium levels are low, Depakote level will be high. So if they're dehydrated, we get a problem. Now, what do we do? Doesn't matter if they have side effects. If that level is from 1.5 to 2, we're sending them to the ER. Okay, if they're having side effects, we're sending them to the ER. If they don't have any side effects, then they're kind of okay as long as it's below 2, but we need to hold it and get that level down and recheck. We can kind of manage on an outpatient basis. However, if that level is over 2, especially if it is a true trough level, we're sending them to the emergency room. If it is 2.1, they go to the emergency room. It doesn't matter. Okay. If they have a true trough level of 3.0, that is a medical emergency, and it doesn't matter if they're having side effects or not. You better send them to the emergency room. Okay. All right, now let's talk about Depakote. I personally, I like Depakote. I think it's a great medication. I use it not as often as I used to, but also I have fewer patients these days. Um, but it's a good one. But it does have some nasty side effects. So this slide is just a reminder of dosing and formulation and all that good stuff. We've already reviewed. We have already reviewed all of this stuff in Psychoform last semester, but there it is there for you, easily accessible. So now let's talk about those labs. So for starters, it does take Depakote about a week to get to steady state. So we're not going to really get a lab. I mean, we're not going to get a level done before at least 7 days. All right. Whenever I'm ordering it, I usually tell people 7 to 10 days, but closer to 7, no more than 10, because otherwise it's going to be too long. Okay, so before we start, we definitely want to get a pregnancy test. Maybe unless that person can prove that they're on birth control or that there's no possible chance of them getting pregnant, then maybe I might be like, all right. But we're still going to want to try and get something on record as to, checking that. So ideally, we're going to get a pregnancy test, we're going to get a CBC, and we're going to get liver function. So we're getting CBCs on Depakote because, or even before we start Depakote, rather, because there's a lot of stuff that Depakote can cause when it comes to blood dyscrasias, as that blanket statement. So we got some things to monitor for. One of the big ones that we're going to monitor for is going to be platelet count, but it can also cause agranulocytosis, and then of course our platelets with the thrombocytopenia. So anyway, so that 7-day mark after initiation, and then every 6 months we're going to give Depakote level, liver function, CBC. Now when we're looking at those levels, therapeutic range is it's actually a pretty wide range. Our identified therapeutic range is 50 to 100. We've really not seen anything beneficial outside of that range. Now there are some folks that we do see benefit and efficacy. They just need a higher dose. If that's the case, then 125 is about the max that we want to go. Anything over 125, we're going to start seeing a lot of side effects, Over 100, we're definitely going to see something. Usually we're going to get that tremor that happens with Depakote. So, sometimes that tremor can happen at much lower doses, and it's just kind of an annoyance thing, and it's just like, well, there's nothing you can do about it. It's just kind of there. The level is fine. Everything else is fine. There's just a tremor. But it's also, one sign that we might have some potential damage to liver and or toxicity happening. So if we do see a level over 100 and they are having side effects, then we want to consider lowering that dose. If they're not having any side effects and they're tolerating it fine, and they're like, no, it's fine, it's good, it works, then we can just leave it. We just might want to, monitor and let them know if they start having these symptoms to let us know. If we see a level over 150, we're going to lower it. We're going to lower that dose, and then we're going to send them to the emergency room if they have serious side effects. All right. The thing with Depakote is that it's a pretty slow-moving damager. It's going to take a minute of high levels for it to really cause some damage. So if we catch it in time, because if we're doing our labs as often as we need to every 6 months, or every 7 days after a dose increase, then we're gonna catch that a whole lot easier, because it's not as that level isn't as sensitive as lithium's is. So we can just lower it and wait a week, get another level, or hold it for a couple of days, then restart at a lower dose, and then get a level. But if they are having serious side effects, and that's going to include, one or depending on how bad that tremor is, or if we have more than one of those side effects up above there, we're going to send them to the emergency room because we could be dealing with some toxicity. Now, those other labs that we're going to look at, we got liver function tests. So it is pretty normal to see some mild elevation in SGOT and SGPT, and that's just because of the heavy metabolism in the liver and just how harsh it is with, on the liver. But if we see any doubled levels from baseline, then we're going to do maybe more of a full workup. Let's just see what else is going on, and refer to a specialist. And then we might also consider stopping the Depakote. Just kind of have to see, that one's kind of a little play by ear, situation by situation, but we at least want to consider the possibility of stopping it. If we see levels triple, then we are stopping it. Probably also need to refer, but for us specifically, we're going to stop it. Now again, thrombocytopenia is one of the more common risks. It's not common, but it's not exactly uncommon either. So it definitely can happen. I've for sure seen it, more than once. It is dose related, so we can decrease the Depakote, get Depakote level, and then also just the dosage itself lower. And we could potentially see that resolving. Not always. Again, that's going to be on a best clinical judgment call as to if you stop it and change it or decrease the dose and monitor. For platelet count, just in general, anything below a 51 is a higher bleeding risk. Most of the time, 50, levels of about 50 to 100 or 51 to 100, that is an area of concern. And so we do need to probably more closely monitor that that platelet count, and definitely go ahead and decrease that dose and see if that helps. Because of course, for the most part, we want that platelet count to be much higher than that. I believe one run around 150 is lower end of ideal. I might be wrong on that. It's been a minute since I looked at platelet counts. Obviously, if someone is pregnant, we're going to stop it or not start it. For breastfeeding, Depakote is actually typically okay. I mean, case by case, of course, but for the most part, it's usually okay. Now let's talk about Tegretol with the generic name that I struggle with all the time. Carbamazepine. I feel like I always try to add an extra syllable in there. Okay, so here's just kind of reminders there. Now, Tegretol is kind of a weird one. Not a lot of people actually get all of these monitoring labs the way that they're recommended, because they're not necessarily required, and a lot of the more serious side effects are pretty rare. So they're recommended, but they're not necessarily required. Also, I can honestly say I don't think I've ever ordered a Tegretol level, because the correlation between level and efficacy is even worse than it is for Depakote. So clinically, do with that as you will, but know that these are the recommended ones. So before starting Tegretol, we're going to get comprehensive panel. We're going to get a CBC and a pregnancy test. Then we're going to wait 2 to 4 weeks after initiation or any dose increase to get a recheck of any levels. And definitely, if we are going to get a Tegretol level, We're going to wait that amount of time because Tegretol actually induces its own metabolism. So it's going to take longer to get to that full steady state, right? So if everything is normal and we're not concerned about anything, nothing is abnormal at all, then we're going to just check every 6 months and just monitor. Our liver function tests are the same as Depakote, although again, it's pretty rare that we have any elevation in any of those levels. Same thing with CBC, pretty rare that we have any dyscrasias that happen. If we do see any, it's that rare leukopenia. The one that actually can happen, and I've for sure seen this one happen, is hyponatremia. Tegretol and trileptal also, similar but not the same chemical, can both cause hyponatremia. So it's good to get those levels and monitor that for sure. And then with Tegretol, we're not going to use it at all in breastfeeding or in pregnancy. Now let's talk about Clozaril. I half jokingly, but also kind of seriously, have always said that Clozaril is a fantastic medication. It's probably one of the best antipsychotic medications that we have. It is considered our most powerful, so it is our last resort. But I wish that it didn't have the side effect of death. And like I said, I'm only half joking about that because death isn't necessarily listed as a side effect, but some of the side effects can certainly be pretty significantly life-threatening. So, before I get into anything with Clozaril, I'm going to jump down to that last bullet. And I do apologize. I did not double check this before I got on here and started recording this. But I believe here within the past year, the Clozaril monitoring system actually has been done away with. And when I first got into practice, we didn't have one. And so I was prescribing Clozaril just, I kind of had to teach myself, which was scary in and of itself. But there wasn't a monitoring system. There was only a pharmacy registry because the pharmacy had to verify ANC before they were allowed to dispense. But we didn't have any systems like any registry. Well, then a few years later, here comes the Clozaril monitoring system, and there was specific training that you had to go through and all of that sort of stuff. And recently, I think they've gotten rid of it. Like I said, I'm going to double check on that and get back to you guys on it. So anyway, so with Clozaril, before we start, we want to get a CBC, we want to get a pregnancy test and an EKG. Think about the side effects with Clozaril that we reviewed last semester. So when we order that CBC, not even after initiation. We're gonna do that before initiation too. We're gonna get the CBC with an ANC. ANC, that stands for absolute neutrophil count, and that is really what we are most concerned about is that ANC. We can see some other dyscrasias happening, but our most concerning one is a drop in the ANC. So anyway, after we initiate, and/or after any dosage increase, we're going to get CBC with ANC every single week for 6 months. If every single weekly ANC is within normal limits for 6 months, then we can move to every 2 weeks. We do that for another 6 months. If after we have a full year of stable dose and normal, unconcerning ANCs, then we can go to monthly. But that is the most that we're ever really going to go with getting labs drawn is once a month. And that should tell you a lot about how risky using Clozaril is. And with our EKG, we're going to get one at baseline, and then every 6 months to a year, depending on what we see there. It is, unfortunately, fairly common to see some arrhythmias happen or worsen, but that is not necessarily cause to stop it, but it is a reason to monitor more closely and collaborate with a cardiologist. So now this is the reason that we're looking at that ANC. We are concerned about a granulocytosis. Now, there is only about a 1% risk. However, I would hate to have a patient that is within that 1%, and then other issues happen. An acceptable ANC needs to be over 1500. Mild leukopenia is somewhere between 1,000 and 1499, and then moderate is going to be 500 to 999. Anything lower than 500 is severe, and it's not good. Okay, that is indicative of an immediate recheck of ANC. We do not dose Clozaril until ANC comes back up over 500. Now, with our serum Clozaril level or clozapine level, we can check that. It's not necessary, but we definitely can. Because what we're looking at, honestly, is we've just got a therapeutic dosage range that is associated with a serum level. So what we have seen is that there really isn't any response until we get to 300 nanograms per milliliter. So, if we're not getting a response, then, and we're at like 400 and we're like, okay, why isn't this working? Then yeah, that might be a reason for a clozapine level. And then anything over 700, any levels greater than 700 are usually not very well tolerated, and then we end up getting a lot of side effects. Excessive drooling is one that I've seen just in general, even with a therapeutic range. That's kind of one of those bothersome side effects. I don't have it in here, but the reason that we're concerned about EKG is because we can definitely have a high risk for torsades with Clozaril. So now let's look at some other tests and just kind of some lab values and kind of give you guys a bit of a reference range. Okay, so first up is sodium. So our serum sodium level should be somewhere between 135 and 145. Hyponatremia is considered anything below 135. Severe is below 125. Symptoms associated with hyponatremia listed there. If a sodium level comes back below 115, that is a medical emergency, and they need to go to a medical facility and suck on a salt lick on their way. No, no, there's better ways. Where medical treatment has progressed a bit more than that. Interestingly, chronic hyponatremia is going to be generally better tolerated than an acute hyponatremia. So when we talk about acute, we're talking about we have dropped into hyponatremic levels over the course of only 48 hours. Whereas if we've just steadily been dropping and dropping and dropping and dropping over the course of months or even, weeks, it's going to be better tolerated, and we're not really going to see those neurologic symptoms quite as severely. Now, hypernatremia is, of course, anything over 146. Symptoms are pretty similar to hyponatremia. So we really, it's hard to tell if you don't 100% know, what the level is, just based on symptoms. Now, serious symptoms are going to start with any level over 257. That can't be right. That should be 157. I just looked at that. As soon as I said it, I was like, that's not right. So serious symptoms are going to be anything over 157. And then death can happen with a sodium level over 180. Please make a note of that. That should be 157. Now, potassium. So potassium, really, really important. Not any more important than anything else, but it's something that we do need to consider with a lot of our medications that it can impact cardiac rhythm. So our normal range is going to be 3.5 to 5. Hypokalemia is going to be below 3.5. There's all your symptoms there. Of course, if we have a critically low potassium level, then that's when we're going to see those ventricular arrhythmias and cardiac arrest. Where we can see kind of a additive risk or collective risk maybe is going to be this risk of torsades when we have a low potassium level and medications that prolong QTC. Well, the problem is that majority of our psych meds have a risk of prolonging QTC. And so that risk for torsades can be pretty significant. So we for sure want to make sure that, we take a look and we're monitoring at those potassium levels on those comps. Excuse me. So levels, as long as the level is above 3, it can be managed outpatient. Anything below 2.5 is going to require, inpatient hospitalization, and for sure, anything below 2.5 is considered a medical emergency. Now, over 5, levels over 5, you've got your symptoms listed there. We don't always see EKG changes, but if we do, it's going to be earlier in the course of I guess the domino effect that can happen with high potassium levels, which is going to get us into VFib and then, of course, sudden death. Levels of 5.5 to 7 are where we're going to start seeing those symptoms. And then anything over 7 is where we're going to start seeing, probably the VFib and things like that. And then at a potassium level of 8.5, that's when that's a fatal level. One of the things that we also want to keep in mind here, this is kind of one of those things that is super special to us psych folks. We've got to monitor these things because majority of our psych medications affect, our electrolytes here, right? Well, on top of that, there are a lot of medical medications that can also cause that additive effect. Imagine if someone is on a diuretic, okay, a non-potassium sparing diuretic, and they're taking an antipsychotic medication that prolongs QTC. And we've got that diuretic that is decreasing their potassium level. We're gonna end up being the ones monitoring for that. And so we just kind of need to, I guess, know that our patients are going to see us more often than they see their medical provider. And so we have to take on a little tiny bit of both roles. I mean, I'm not necessarily gonna treat hypokalemia or hyperkalemia, but I definitely will monitor. And then we've got calcium. So we've got two different labs that we're going to see with calcium. We can get that serum, or we can see the ionized calcium level. For hypokalemia or calcemia, gosh, what am I saying? Hypocalcemia. When we see that ionized calcium level of below 4.6, those are the symptoms that we're going to see there. Interestingly, our low calcium levels are going to be caused by vitamin D deficiencies, hypoparathyroidism, and we have to keep in mind that a lot of our patients are already struggling with a vitamin D deficiency. That's kind of the big one. So again, another reason that we kind of we got to pay attention to some of this stuff, more so than we think when we get into psych. Hypercalcemia. I don't know why I keep trying to say kalemia. Calcemia. You got your levels there. We've got basically any level that's greater than 10 is considered critical, and we could actually have death result in that. Full-on heart blocks. Now, vitamin D, we have to have vitamin D in order to absorb calcium. So there's kind of just going along with what I was just saying. Normal levels are going to be 20 to 50, depending on how they're reported on the lab sheet, but usually between 20 and 50. Below 12 is considered clinically significant, and this is why. Yeah, you guys can read all that. I don't think there's anything more I really need to add to that one. Now for renal function. So let's see how many times I can say creatinine in one sentence. So we're going to monitor renal function through our BUN creatinine ratio, brachial creatinine level, creatinine clearance, and urine creatinine. Normal range listed there. Of course, that's going to vary with age, especially with our BUN. And then our GFR, we really don't look at GFR unless there's other indications that there might be something going on with the kidneys, until certain ages. And I'm going to tell you right now, I am not a nephrologist, and I am not sure when they actually start monitoring that. I don't know what the age cutoff is off the top of my head. But just know that there is that. Typically, a GFR below 60 is going to indicate some sort of moderate kidney disease when it's within context of other abnormalities. When we see an elevated BUN or creatinine, or I'm sorry, BUN and creatinine ratio, that is going to indicate a problem prior to the kidney. So it's not a kidney issue, all right? That elevation is going to be due to, most of the time, dehydration. And when there's dehydration, obviously, that's going to cause problems for us, not just for their patients. If there's a lower ratio, that's actually going to indicate more of something actually going on with the kidneys themselves. And anything past that, that's for specialists to deal with. Now for our liver function tests. Our aspartate aminotransferase, our AST or the SGOT, and then we've got our alanine aminotransferase, that's our ALT or our SGPT, and then we've got alkaline phosphatase, NGGT. Now, just depending on the particular lab, you might see those listed as AST, ALT, or SGOT and SGPT. The alkaline phosphatase and GGT, I don't think I've ever really seen those listed as anything different. Other things that we're going to check with liver function tests, if we do that whole liver panel, we should also see a PT-INR if it's going to be decreased with any type of liver disease. Our albumin levels are going to be decreased with liver disease. Our bilirubin is going to be increased with liver disease. And then our ammonia levels are going to be increased. Our ammonia levels are going to be the most concerning out of all of this. Now, granted, liver disease, liver damage is definitely concerning. However, elevated ammonia levels can actually cause some acute encephalopathy. And then if that happens, the rest of this is going to be the least of our concerns. So when we are going to get a thyroid panel, thyroid function test, we are going to be looking at TSH, T4, free T4, and T3. Now here's all your levels over here and some medical causes. This is some of the things that we do need to think about, is that if we have an elevation in TSH, and we're not prescribing a medication that is really going to impact TSH. We're just kind of getting it because maybe depression, and we're just kind of checking. There's a lot of causes, but one of the things that can also be associated is those pituitary adenomas. Now, let's say we are prescribing, let's say Risperdal. Risperdal can cause some pretty significant issues with the pituitary, and could actually be linked to the development of some pituitary adenomas. So that's problematic. Now, of course, our TSH is going to go low with hyperthyroidism, and that could potentially be due to some hypothalamus diseases, or disease rather. So those are TSH normal range. T4, or our thyroxine, is going to be elevated in hyper and then low in hypo. So it actually follows, that normal expected pattern. Not like our TSH, which is always opposite. Then we've got our free thyroxine, or free T4, and that is going to be the biologically active form of TSH, essentially. That's what's actually going to do something, right? And then just in general, if we're going to get a T3, that is just the total amount of unbound. So that's going to include, active and inactive. Diabetes, here's just kind of a range of our hemoglobin A1Cs. I've never seen any medical provider get excited until we see a A1C of 6.6, 6.8. That's when they start getting excited about it. Prior to that, they're just like, stop eating that diet, do better. So just to keep that in mind, just so that you know these levels, because I do ask my patients these levels. And then we've got our lipid panel. We do have the option, I guess, of intentionally getting a non-fasting. The question is it better to get lipids when they're not, when someone is not fasting, than just to not get them at all? Me personally, I think that I would rather have lipids and just note that the person was non-fasting, or document what they had to eat. I have a lot of people that they're like, I couldn't get in the doctor to get my labs done until 3 p.m. There's no way I can go all day long without eating. No, normally they only have to go 8 hours, so they could have, potentially eaten something at breakfast. But, you never know. There was one time I know I went to the doctor and I completely forgot that I was getting labs done, and I pulled up into the parking lot eating fast food. So, it happens. But again, I would rather have them on record than not have them at all. At least I've got something to go on. So our total cholesterol, and of course this is, it's steadily getting lower and lower, all of these numbers. So, just kind of stay up on what we want. But right now, normal cholesterol is anything, below 200. I think they're kind of pushing that to 195. Also, I think I've seen that here and there. And then we've got our LDL and our HDL, and our triglycerides. And those are kind of the levels that you want to see. So that is all for this lecture. Let me know if you have any questions, need any clarification. And that's all I got.